This is a very simple and very straightforward question. And if I was the student and I saw this image, I'll be very happy to answer this. First of all, lateral neck radiograph. You can see that lateral neck radiograph showing air fluid level. Can you see air fluid level? Even if you don't know what disease this is representing, air fluid level must be clear. Can you see that? This actually is a picture of retropharyngeal abscess. Retropharyngeal abscess. Retropharyngeal abscess. Now in this retropharyngeal abscess, if you pay a close attention, see the normal curvature of the cervical spine is lost. Normally cervical spine would have been like this, but now it has become like this. It has become concave anteriorly. It should have been convex anteriorly, but now it has become concave anteriorly because of this lesion, And you see, this is air, this is fluid, this is air fluid level. So it means there is acute pus, there is active pus right now over here. Now, if you pay attention and look at the image again closely, you will see here you can see the air column. This is because of the trachea. Can you see that? Then this will be the retropharyngeal, behind the pharynx. Retropharyngeal abscess, air fluid level, and loss of curvature of the vertebra. Very simple. Okay. Again, let's move to the next. Okay, this is also one of the very common and very easy radiographs. This is Waters view. I think most of you would be aware of the same Waters view, or X-ray PNS as we call it, X-ray of the paranasal sinuses. Here also I can see air fluid level. In which sinus? This is which sinus? Maxillary sinus. This is a very old radiograph of a patient I had. Hence, other things are not clear in this, but what I wanted to show you was the air fluid level on both sides. Here also air fluid level. Can you see it? I've marked it. Now I'll erase it so that you can see it clearly. Can you see the air fluid level? So this picture represents acute maxillary sinusitis with air fluid level, which means there is active pus. There is pus right now in both the maxillary sinuses. Okay. Now moving to the next picture. This is one of the latest pictures, and I feel this can be a part of the questions in the upcoming papers. So what is this? What is this person using? First of all, if you notice, this person has permanent tracheostomy. Permanent tracheostomy has been done. Now this permanent tracheostomy means, you see this trachea is coming and opening out outside. There's no continuity above, right? So this is permanent tracheostomy. I'll remove this. This is permanent tracheostomy. So it means laryngectomy has been done. This is a picture of post laryngectomy, and that too total laryngectomy. Total laryngectomy. So this much is clear in my brain. When I see this picture, this should come to my brain. There's no larynx, the trachea is coming and opening outside directly. So this is a case where total laryngectomy has been done. This is a post-operative case. Now this person has blocked this and is using air from the trachea, which is going through a device into the esophagus. And this he is using to speak. So this is something to do with the speech, right? This is actually tracheoesophageal speech with the help of, what is this? This device we call as the tracheoesophageal device, or you can say tracheoesophageal. Actually, this is speech prosthesis, tracheoesophageal prosthesis. We insert it by doing TEP, that is tracheoesophageal puncture. So we have to create a hole over here to insert this device so that this can be used. So whenever the patient has to speak, he'll close his trachea outside, the opening outside, and he'll try to speak. When he tries to speak, the air which is coming out will be shunted to the esophagus, and this has a valve. So this place has a valve. This place has a valve that it will allow movement of things only in one direction. Nothing from the esophagus can enter the trachea. So it's very clear. This person is trying for tracheoesophageal speech, right? Tracheoesophageal speech, because this question can have multiple options like, what is this representing? Tracheoesophageal speech, esophageal speech, or electronic speech, or electro speech. You must have seen those electronic boxes people put over here while they are trying to speak. So this is what? This is tracheoesophageal speech with the help of primary prosthesis. Primary tracheoesophageal prosthesis. Okay, let's move to the next image. What is this? What are we seeing? First of all, what procedure they would have done to see this? They have done laryngoscopy. Laryngoscopy. Which laryngoscopy? Video laryngoscopy. Because this is a picture taken with the help of camera, right? Now we can see vocal cords. Can you see the vocal cords? Vocal cords. True vocal cords. This is false vocal cord. Now the important thing over here is this. Everybody can make out, right? This is anterior, this is posterior. So this will be the posterior commissure. This will be the anterior. Here, you can see at the junction of anterior 1/3 and posterior 2/3, this is vocal nodule. And if you again use your brain and try to see, they are opposing each other. Why? Because what happens is, if one side there is a nodule, this, whenever this comes close, this touches this side, because of friction causes a nodule on the other side also. So this is nodule, bilateral vocal nodule. Okay, this is most common in teachers, surgeons, or the people who have history of speaking more. Surgeons I told, because even me, I'm taking classes. So doctors who take classes, or people who have habit of speaking, who have continuous speaking, like who have a profession in which they have to speak for long hours, they can have this vocal nodule. Okay, let's move to the next image. This is one of my favorite images because this comes in exam, and this is sort of a game changer. What happens is, most of the students know only one thing. I think everybody will be able to answer this. What is G? This is Killian's dehiscence. Killian's dehiscence, right? Everybody knows this. Everybody answers this, that this is Killian's dehiscence. And from here, a mucosal pouch can come out, that is called as Zenker's diverticulum. Everybody knows that. Okay. Now the game changer question. What is M? What is P? M is also a dehiscence. This is in the upper part of the esophagus. So here esophagus starts, right? Only this part you can see is dehiscent and does not have outer longitudinal fibers of esophagus. This is called as Lymer's dehiscence. This is called as Lymer's dehiscence. And once this has been asked, that they have marked this instead of that, and most of the students answered it as Killian's dehiscence, and it was not. It is Lymer's dehiscence. Clear? Okay, then this whole area, this also is dehiscent actually, because you see here there are two layers. Dehiscence. This area is also deficit and can also have a dehiscence over here. What is this area called? Overall, what is the name of this area? This area is called as KJ area. So the P which I have marked, this is KJ area. Now what is K and what is J? KJ area is Killian. It's Killian's, or I can say Killian Jameson. So Killian's and Jameson's area. Killian-Jameson's area, KJ area. So this is one of the questions that might be asked, and is one of my favorite questions, because remember all three. Do not focus on anyone. This is my take on this. That is why I've put this image here, because mostly students, the mistake which they do, this question can come and they'll not have any arrows. They'll not put any arrows at all. They'll only put one arrow, even if they put it over here, and they may ask, what is this? What does this arrow represent? Lymer's dehiscence, Killian's dehiscence, KJ area, and they'll put one more name. And most of the students will be marking it as Killian's dehiscence, and that will be wrong. So you'll be losing marks on such an easy question. So do not do that. Let's move to the next question. Okay, this is related to malignancy. That is my hint. So what is this? What does this P represent? That is, what is this? Which line? Ohengrens or Ohengreen's line. Ohengreen's line. Okay. Now you can see this passes through the medial canthus and angle of mandible. Importance of this line, as per the person, as per Ohengreen, he felt, and even today we believe that malignancies of maxilla which cross or are above this line are difficult, have a poor prognosis, are difficult to operate actually. Malignancies below this line have a very good prognosis and are easily operable as compared to the malignancies which are above this line. So this is Ohengreen's line. Okay. Next, let's move to the next image. This is a very, very frequently asked question for ENT. Do not think that this is a question of pathology. However, you may read this in pathology as well. But this is a very important question from ENT point of view. If you look closely, I'll say there can be many histopathological pictures in ENT. 3 I have put, this is just one of them. Just focus on one thing. You see, from outside, this thing is growing in. Like, this is the matrix. From outside, things are growing in. See, this is normal air. From outside, something is growing inside the stroma. From outside, something is growing inside the stroma. So this is backward growth. Inverted growth. That's the hint. Inverted growth. So this is inverted papilloma. Inverted papilloma. What are the other names given to inverted papilloma? Ringer's tumor. Ringer's tumor. Other name? Schneiderian. Schneiderian tumor or Schneiderian papilloma or inverted papilloma, as you already know. So this is again very simple. Like if you see the image, it will be very clear. Something is growing from outside. You see, something is growing from the outside part. Something is growing from outside backward into the stroma. This is very easy to identify. Ringer's tumor or inverted papilloma. Let's move to the next picture. What is this? This will be a straightforward question. What is the procedure being done or what is the procedure shown? This is frontal. You must be able to make out that we are doing something with the frontal sinus. Frontal trephinization. Trephinization. Now, why do we do this? Whenever there is frontal abscess and there is pus in the frontal sinus and we feel that because of the antibiotics and everything, we have tried everything and it's not healing and the pus is not draining, we can give an incision medial-superiorly or superiorly and medially to the eye or medial canthus and open up the sinus and drain the pus. This is frontal trephinization. This is done obviously along with the intravenous antibiotic cover, but this procedure, if they ask, this is what? Frontal trephinization. Simple, straightforward question. Let's move to the next. Okay, this is also a very straightforward question. Identify the incision given in this diagram. What is this incision? The name of the incision is Weber-Ferguson incision, used for maxillectomy, medial maxillectomy. Okay, maxillectomy. In the cases of maxillary carcinoma and there are other options also. There are other diseases also in which we have to do maxillectomy because of providing space to reach infratemporal fossa or other things, but you don't have to go into that detail. Just remember, this is Weber-Ferguson's incision done for medial maxillectomy. Simple, straightforward question. Let's move to the next picture. Okay, another histopathological picture. I know histopath is not the favorite of most of the students, but still. But this is very clear. Can you see a sporangium over here? This is a sporangium, right? And inside you can see sporidia, already formed sporidia. Here, another sporangium. Now from the name only you would have got sporangium. So this is case of rhinosporidiosis. Rhinosporidiosis. What is the causative organism for rhinosporidiosis? Someone? Did you answer? Okay, I'll only tell. Rhinosporidiosis, Seabury. Right? So this is one of the causative organism. In this picture, you can see a sporangium in which there are multiple preformed sporangia. So this is simple, straightforward question. Let's move to the next one. Okay, first of all, Identify what is this, what picture I have put. First of all, identify. Let me see how many of you can identify this picture. This picture is showing sphenoid sinus. Sphenoid sinus. Now in the sphenoid sinus, these are the structures which they may ask you to mark. These are the relations of the sphenoid sinus. So if you have read the sphenoid sinus, you'll be able to answer this. This is optic nerve. This is optic nerve. Optic nerve. This is internal carotid artery. Very simple. Let's keep it simple only. Okay, this maxillary nerve. Maxillary nerve branch of trigeminal. Very simple. Keep it simple. Now, the question which is always asked in this is, what is this nerve? This is of importance because this is what people usually forget. This is VDN nerve. VDN nerve or nerve of pterygoid canal. This is that nerve which is very important because people usually forget it. One extra pointer I'll tell you over here. This recess over here is called carotico-optic recess. Carotico-optic recess, and is of importance surgically when we are performing a surgery. Okay, so this is done. This image is done. Let's move to the next image. Now, what is this image? This is a patient lying in front of me while I am performing a surgery. So, question will be, what is the name of this position? Or what is the name of the surgery being done? Or describe the position. Like they'll be in this position while operating the patient. The neck is extended or flexed, head is extended or flexed, or there is extension at this joint or that joint. That can be the question. That's how they can frame the question. So first of all, this is rose position. Surgery being done, tonsillectomy, can be even adenoidectomy. Now in this very important thing, extension is done at level of neck. So neck is extended and head is extended. See, these are two different things. How? I'll tell you. First, I'll try to draw so that you can understand. I'll draw as I always draw, our helpful friend who will help us learn. This is the vertebral column. Okay. This is normal. Now, if I have to extend the neck, only the neck. If I extend only the neck, the person will become, his neck will go back, his head will be still like this. So extension has occurred at neck. Neck is fully extended. Okay. Head is still like this. Now if I extend the head and keep the neck straight, how will the person look? Only head extended. I'll show you. Wait. I'll draw it like this. Neck straight, person straight. So neck I'm keeping straight. Head I am extending. So now what happens is, this neck is normal, his head is extended. So in this position, rose position, both are done. This is done at level of which joint? Mainly they'll ask which joint. So this is atlanto-occipital joint. Atlanto-occipital joint. So extension at atlanto-occipital joint as well as extension at cervical vertebrae. So they may ask, what is true about the image? Name is rose position, is used for tonsillectomy. There is extension at atlanto-occipital joint only. There is extension at atlanto-occipital joint and cervical vertebra. So you have to answer. So only atlanto-occipital joint becomes wrong because there is extension on both the sides. So there is extension of the neck and extension of the head, both, right? Understood? This is rose position. Let's move to the next question. Again, and I'll say this is last of the histopathological images I'll show you. Okay. Just to identify, even if you have no idea about what this image is, just look at some basic features which even I can make out. These are vacuolated. These cells look like they're empty, right? So there are vacuoles in these. So I know one disease where there's a cell. In that cell, Cytoplasm has a large vacuole and it looks empty because of that. What is that? Where do you see it? Rhino Scleroma. Rhino Scleroma. Okay. Rhino Scleroma is caused by Klebsiella rhinoscleroma. Okay, then causative organism, you know. Other thing. What is the name of this cell? They may ask, kindly mention the name of this cell. This cell is called Mikulicz cell. Right? What does this arrowhead show? Chronic inflammatory response. Lymphocytes. Chronic inflammatory response. Right? So, chronic inflammatory response. So, it's very easy. All the three pictures which we have seen today. One, remember, growth from outside to inside, inverted papilloma. Second, sporangia was clearly seen, so rhinosporidiosis. Third, you can see vacuolated cells. Mikulicz cells are easily seen over here. Then there will be plasma cells over here in which there will be inclusion bodies that right now I will not show you in this picture because it's not zoomed. It is low power picture of microscope. But again, a point they may ask in the question. What inclusion bodies are seen in this condition? What are those inclusion bodies called? Russell bodies. They are seen in rhinoscleroma. What are the cells? Mikulicz cells. There's chronic inflammatory response. This you can see, right? And the Russell bodies, which are inclusion bodies in the plasma cells, which is not shown over here right now. So this is the image and this is the question. I hope this session was a good session. These 30 images will help you not only to prepare for exams, but quick revision. You know, these images will give you a quick revision of all three parts of ENT: ear, nose, and throat. Stay healthy.